All right. So it is 5:01, so we'll get started. Good afternoon, everyone, and welcome to Trinity Health of New England Orthopedic Movement Matters webinar series. We appreciate you taking a few moments of your time to be with us to discuss orthopedic-related topics of interest to you and your family. Please remember to mute your microphones. You can click on the microphone on the top right corner of your screen. Once it's muted, you should see a little slash through it. My name is Dan Gould, and I will be your host for today's webinar. We plan to present as an ongoing educational series on the second and fourth Thursday of each month from 5 to 5:45. Today, our guest speaker is Dr. Eric Carlson. Dr. Carlson is the Section Chief and Associate Medical Director of Orthopedic Surgery at St. Mary's Hospital in Waterbury. Dr. Carlson will be speaking about carpal tunnel syndrome. We'll have a presentation followed by questions and answers. And if you'd like, in the chat function, I submitted the anonymous website. So if you aren't comfortable putting out your questions to the public, feel free to use that link. So without any further delay, let me turn it over to Dr. Carlson and we can get started. Dr. Carlson?
Great, thank you, Dan. And I want to just thank you and everyone at Trinity for setting all this up. I hope everyone can hear me okay. And hopefully this will be a brief but informative discussion. And I'm hoping that people have some questions at the end that makes things a little bit more interesting. Again, my practice is located in Middlebury, Connecticut, just over the Waterbury line. The majority of the work I do is at St. Mary's Hospital and their affiliated Naugatuck Valley Surgical Center. And I do see patients of all ages, mostly upper extremity. I do see some lower extremity sports injuries as well, but my specialized private practice is really shoulder to fingertips. So carpal tunnel is something that I deal with. Carpal tunnel syndrome is something that I deal with on a very regular basis. So hopefully this will give you some background information and spark some discussion towards the end. So let's go ahead and get things started. Dan, I guess there's the questions. So if anyone wants to submit things via anonymous website, there's the address. So carpal tunnel syndrome is very, very common, and we're going to get into a little bit about how common it is. You can hit the slide there next. I like to think of carpal tunnel, which is what's called a compressive neuropathy, as something that's causing pressure on a nerve. And I liken it to a garden hose. So I call it kind of the garden hose effect. So when I'm talking with patients in the office, I think this is a good way to describe it. Anything that causes pressure on a garden hose, whether it be your foot or a car tire or any type of heavy object, is going to stop or slow the flow of water. And the same goes for a nerve. So a nerve you can think of somewhat like a garden hose, although obviously it doesn't carry water, it carries a signal. But if anything is pressing on that nerve, you're going to get some downstream effect. So if you put your foot on a garden hose and you're trying to water the lawn dies because it's not getting water. And similarly, if something is putting pressure on a nerve towards the upper part of the body, the downstream effect can be seen by changes in the way you can feel things or even how you can move the extremity, in this case, the hand. So we'll go into the next slide. There are many different types of compressive neuropathies, and there's a few that I've listed on this slide. But the one we're going to be talking about today is carpal tunnel syndrome, which is by and far the most common, the one that you hear about, the one that your friend or your uncle or your coworker had and has had to deal with. And what that is pressure on the median nerve. The median nerve is one of the main nerves that supplies the hand. And really, that's the one we're going to be speaking about today. So even though I've listed a few other ones up here for your reference, the compressive neuropathy, meaning a pressure on a nerve, today we're going to be talking about is pressure on the median nerve, or carpal tunnel syndrome. Go ahead, Dan. So the etiology of any compressive neuropathy again, this is expanding on the idea of the garden hose effect, is tightening of the tunnel. Okay, so the median nerve, along with most nerves in the body, at specific places in the body will run through a tunnel. And if that tunnel is too tight for whatever reason, you get downstream effects. The other thing that can happen is that the nerve or anything else that runs with the nerve through the tunnel can get swollen or increase in size, and that can essentially lead to the same effect. So you're talking about less space for the nerve, which means there's increased pressure on the nerve. And what that does is it causes less perfusion to the nerve. What's perfusion? Perfusion is blood supply. Blood supply is what feeds the nerve. It's what the nerve needs to live and to function appropriately. So if you don't have perfusion because of pressure on the nerve for whatever reason, you're not going to get good function. Next slide. So any compressive neuropathy, including carpal tunnel syndrome, will result in symptoms such as tingling, burning, maybe an electrical or shocking type of pain. This can occur at night or during the day. These are called paresthesias. That's a fancy word just to describe these sort of nerve feelings that you might have. You're also going to have potentially decreased sensation or numbness in the fingers. So this might cause you to feel like you can't button your shirt or pick up a piece of change. And the next thing after decreased sensation that can happen is weakness. So the last sort of downstream effect, the worst effect, is loss of motor function, which means you might not be able to grab something as strongly as you once could, because the muscle, just like the skin, is supplied by the nerve itself. And if the nerve isn't functioning, the muscle isn't going to function either. Next slide. All right, so let's get straight down to carpal tunnel syndrome. We'll talk a little bit about where the carpal tunnel is first. So carpal tunnel is actually an anatomic structure. The slide on the right, you can see, is taking a slice through the wrist, right at about where the hand and the forearm meet. We call that sort of the proximal wrist crease. And right at that level, you can see this is the cross section. You have the small bones of the wrist on the back of the hand. And on the front of the hand, where the palm is, you have a thick, soft tissue structure called the transverse carpal ligament. Inside the tunnel that's formed by the transverse carpal ligament and the bones of the wrist, you can see there's multiple structures. Those are called flexor tendons. For the purpose of this, they're just the ropes that allow you to flex the fingers. And then alongside that runs the median nerve. And that's what makes up the carpal tunnel. Move on. So knowing where the carpal tunnel is and that it's actually an anatomic structure, let's talk about the demographics of carpal tunnel syndrome. Carpal tunnel syndrome is the most common peripheral compression neuropathy. Remember, I had a long list of different compression neuropathies. Carpal tunnel is the most common, and that's one of the reasons why we're talking about it today. At any time, 3 to 6% of the US population has carpal tunnel syndrome. That's a pretty impressive number. 8% of the US working population will have it at one time. Workers' compensation claims. So workers' compensation, for those of you who aren't familiar, is when there is a work-related injury or ailment to the body, and people can report that, a worker can report that. So workers' compensation claims in the mid-90s, which is the most recent, it's kind of outdated, and I apologize for that, but that's the most recent data I could find for this. There was a peak of almost 3 per 1,000 workers' compensation claims were just for carpal tunnel syndrome. So there is some obvious association with work-related activities in specific work environments. If you look at the importance of that, is the median time lost at work is about 28 days, which means that it's a significant driver of missing work. So carpal tunnel is not only common, but it also can cause a significant disruption in the lives of patients and obviously the lives of your workplace. Moving. So how does carpal tunnel happen? Why does it happen? Well, it's multifactorial, meaning that we don't know who's going to get it or when they're going to get it exactly, but we do know that there are some specific risk factors that put you at a higher likelihood of developing carpal tunnel syndrome. So environmental factors, the things that are around us, or the things that you are forced or have to do on a daily basis include hand and wrist position. So positions in flexion of the wrist and extension of the wrist instead of a neutral flat position of the wrist can increase the risk, of developing carpal tunnel syndrome. And then occupational exposures such as repetition of that flexion extension of the wrist, or any repetitive activity that leads you to have to flex and extend the wrist on an intermittent and repetitive basis, as well as vibration. And vibration actually turns out to be a really big driver of carpal tunnel syndrome. Medical factors. Risk factors include diabetes, obesity, hypothyroidism, alcohol use, tobacco use, and then inflammatory disorders like rheumatoid arthritis and lupus, which are the two most probably common ones that I see, can increase the risk of carpal tunnel syndrome. For whatever reason, women are more commonly affected by carpal tunnel syndrome than men, but we certainly see it in all categories of patients. So there's a big thing, and I almost always get asked this in the office about what about computer use? So do computers cause carpal tunnel? Well, there's some debate about that. Next slide. So, this is, pretty much right out of a review of that was titled Association Between Work-Related Biomechanical Risk Factors and the Occurrence of Carpal Tunnel Syndrome. So this is basically looking at the question, is there an association with computer use and carpal tunnel syndrome? And as you can see, in this particular study, they could not establish a specific association between computer use. That being said, recent primary studies supported existence of a significant relationship between carpal tunnel syndrome and repetition, force, and combined exposure. So the takeaway from that is it's probably has something to do with it, but it's not clear cut. So every case when I have a patient come in and ask me, oh, I use the computer all the time, is that what's causing it? I go through all of those questions, look at all their risk factors, and I may or may not be able to say, yeah, it is causing it, or it isn't causing it. But certainly there is probably some association with it. We just haven't figured out exactly how to tease it out yet, because there are so many other risk factors for carpal tunnel syndrome. Next slide. So again, risk factors, this is just what we call the American Academy of Orthopedic Surgeons has developed these clinical practice guidelines, which have been very helpful. Over the past decade or two, they've come out with these guidelines for practitioners, surgeons, and physicians to follow. And they kind of give us an idea of what the best practices are. They give us ideas of what the evidence actually shows. And it gives us a guideline for treating patients as well as what to tell patients. And this list right here, as you can see, shows that there's strong evidence based on the academies, which is our big professional organization that we trust, that there's strong evidence that increased BMI, so that's body mass index, usually associated with obesity, high hand and wrist repetition rate do put you at a higher risk of carpal tunnel syndrome. As far as other things, the moderate evidence, so that means sort of one step below that, so the risk factors but not as closely related. And I'm not going to go through the whole line, but you can see vibration, computer work, assembly line work, etc. So there certainly are associations with activities that we commonly do on a daily basis. Next slide. So how do we make a diagnosis of carpal tunnel syndrome? So it's a combination of both history, so your symptoms, and clinical findings when you come into the office. So your history might tell me that you have, or another practitioner that you have, numbness and tingling. It might be every now and again. It might be all the time. It might be every night. I ask, how long has it been going on for? And then on clinical examination, there's a couple of things that I look to. In the beginning, probably the most common thing is what's called the Tunnel sign. So I might take your wrist and tap on the wrist, right where the carpal tunnel and the median nerve is. And if you have some tingling in the fingers, that's a sign that there's some irritation of the nerve, which can be a sign of carpal tunnel syndrome. There's a couple other tests which I might perform to try to elicit some of the symptoms that you have, such as numbness, tingling, burning sensation in the hand. Likely test sensation. Obviously, if you have less sensation in the fingertips, it's a sign that you may have carpal tunnel syndrome. muscle weakness, so weakness in grip, or even what we call atrophy. Atrophy is a word that basically describes loss of muscle. So if you look at your right hand and it looks normal, sort of the contours of the hand are normal, what we consider sort of average, and then you look at your left hand and there's some hollowed out areas near the base of the thumb, for instance, that's what we call atrophy, and that's a bad sign, because that means that carpal tunnel, the median nerve, or this carpal tunnel syndrome, has been going on for a very long time. Next. So if you come into my office and you have a history that matches some of the findings of carpal tunnel syndrome, you have some findings on examination, and we want to get a little bit more information so I can help guide treatment, the recommendation by what's called the ASSH, which is the American Society for Surgery of the Hand, which is similar to the American Academy of Orthopedic Surgeons. It's a licensing board, and that people who deal with hand surgery and wrist surgery and elbow surgery apply to. They have their own clinical guidelines, and their recommendation, along with my recommendation, I agree with this recommendation, is to have what's called electrodiagnostic testing. That's a test that's usually done by a neurologist or a physiatrist in this area of the country. And they're basically using a test with electrodes, which go onto your arm or pasted onto your arm to evaluate the health of the nerve. They can do a couple of things. The biggest thing for me is that it can localize the point of compression, because along with carpal tunnel syndrome, we want to make sure you don't have pressure on the nerve in another area, up in the neck or near the shoulder, or if any other nerves might be affected. The other thing that it tells us is the severity of the compression. So if compression is very severe, I'm going to be able to counsel you better to tell you, yes, you probably need to have a surgery. If you do have surgery, you may have a longer recovery, so on and so forth. So it gives me a lot of information and allows me to give you a lot more information about what's going on in your wrist. Next slide. So let's say we make a diagnosis of carpal tunnel syndrome. We've gone through the whole process. You come back to my office. We review all the results of the nerve study or the electrodiagnostic study. We talk about treatment. So the biggest things for treatment in carpal tunnel syndrome are splinting and injections. Those are the first line of treatment. When I talk about splinting, you can see there's a picture of a basic wrist splint up on the screen. A splint just basically allows the wrist to rest in a neutral position. As I said before, one of the risk factors of carpal tunnel syndrome is wrist repetitive flexion and extension. And so if you're in a job that's having you do a lot of wrist flexion extension, or you're doing an activity that causes that, it might increase the risk of carpal tunnel. And if we stop that, it might lower the risk of carpal tunnel or even alleviate some symptoms. Most of the time, my recommendation is for night splinting. We have a tendency when we sleep to curl our wrists in flexion, and that actually puts pressure on the nerve, the median nerve, which is obviously the nerve that we're dealing with here in carpal tunnel syndrome. So if we can take pressure off the nerve with a splint that keeps our wrist in a neutral position, then we may have a decrease in our symptoms. So instead of waking up in the middle of the night with numbness and tingling, you may be able to sleep through the night with a simple wrist splint worn at night. So that's obvious. That is always the first line of treatment, especially with patients with night symptoms. The second line of treatment is what we call a steroid injection. Steroid is an anti-inflammatory. We're not talking about steroids that make you big and muscular. We're talking about steroids that reduce inflammation. So this is similar to prednisone, methylprednisone, which you may have taken if you had a bad asthma attack or if you had poison ivy. So all it's doing is effectively decreasing the inflammation and swelling around the nerve, which again, as we talked about before, the problem is that there's not enough space for the nerve. It's under pressure. If we reduce the size of the nerve and the tissues around it by reducing inflammation, then we may have improvement. That can be done in the office very easily on a regular office appointment. Medications are not usually that helpful. Physical therapy doesn't really support the use the data does not really support the use of physical therapy, although if there's any physical therapists on the line that want to tell me about some good methods that they've had success with, I'm happy to talk about that. But basically, the two that I mentioned, two interventions is splinting and splinting and injections are the first line treatment. Next. As I said before, splinting at night is recommended in all cases first-line treatment unless it's very severe. And ergonomics during the day can be effective. So I have a lot of patients that have very poor ergonomics, especially now that patients are working from home. They're working on a laptop. They don't have appropriate equipment, and their wrists are in all weird positions when they're typing. This is really important, especially in today's world. Next slide. So injections are effective, especially for short-term relief. As I mentioned, it's an anti-inflammatory steroid injection. There's a good paper published a few years ago now, 6 weeks symptom relief in 79 or almost 80% of wrists, 6 months at 50%, 12 months, 30%. So as time goes on, the steroid injection wears off, essentially. That's what this is telling us, which is what we would expect. So if you go through all of this treatment and it's not working, or it worked and has stopped working, or the symptoms have returned, or in certain cases which are very severe, such as patients who have atrophy, there's very, very strong evidence to support that surgical treatment of carpal tunnel is effective. So we do this in, again, 2 instances: either failure of non-operative treatment, meaning that you're still having symptoms, or in severe cases, or certainly recurrent cases if you've already had surgery and it came back. Next slide. So surgery for carpal tunnel syndrome can be done in 2 different ways. You may have had colleagues or friends or relatives who've had either an open or mini open technique, where there's an incision made in the palm, versus an endoscopic technique, which is a much smaller incision in the palm. And the question is, on the wrist, not on the palm. So there's obviously benefits and risks to both. You can see them up on the list in front of us. The question is there a difference? Should patients be looking to get open or endoscopic? And how do we make that determination? Usually it's the surgeon's preference, because the surgeon may only perform endoscopic primary, or may only perform open. But this is certainly a discussion you want to have with your surgeon when you're indicated and told that you need to have a carpal tunnel release. Next slide. So here's a picture. I think this is one of my cases doing an endoscopic technique. We're looking inside the carpal tunnel. Above to the top of the screen is the ligament, and what we can do is release a little blade, which I didn't show, and then release that transverse carpal ligament and take the pressure off the nerve. So that's what we're seeing here, is just a before and after release of that ligament. And that's how we do carpal tunnel surgery. We release that ligament, whether it be from inside endoscopically, like I just spoke, which is a small video camera that goes inside of the wrist, or an open technique, which is a larger incision and you're cutting from the top instead of inside. Next slide. So if you look at the differences between the two, essentially this is the difference. There's 3 main differences. So in endoscopic, which is a smaller incision, you get an earlier return to work. There's improved strength in the post-op period. The results at 6 months are are similar, and endoscopic technique has decreased scar tenderness, but especially in especially in early cases when they had earlier technology. I don't think this is the case anymore, based on some newer studies and other evidence. There was an increased risk of nerve injury initially. The technique and the technology have improved significantly. I don't think that will bear out in the newer studies. Next. So after surgery, the post-operative course, what can you expect? So you're going to have some pain, and the pain is actually, especially if you have the endoscopic technique, is not going to be where the incision is, which is interesting, because the incision is actually up the forearm or up by the wrist, and the surgery itself happens in the palm. So you're going to have some soreness in the palm at the base of the thumb. We call that pillar pain. It can last 2 to 3 months even. I don't generally send patients all to physical therapy. I see them at 2 weeks and see how they're doing. If they have stiffness, if they have a lot of tenderness, I might send them to physical therapy for motion, for desensitization, and then return to work. It really depends on the job description. I have some patients that go back to work after endoscopic carpal tunnel the next day. They just have a dressing on. But if you have to use your hands for a living, moving things, picking up any repetitive activity, these types of manual jobs that may take 6 to 8 weeks for full duty. My expectation is generally 4 to 6 weeks, but I've seen kind of the gamut from a day after to 3 months. Sometimes we'll do a workplace evaluation, which just means I might ask you what your job actually entails and see if we can figure out a way that you can get back to work and not be uncomfortable or re-injure yourself. Next. So that's sort of the overview of carpal tunnel syndrome. I know that was a lot of information in about 20 minutes, maybe a little over 20 minutes. But I hope it gave you an idea of what carpal tunnel syndrome is, which is essentially, think of it as the garden hose effect. Not enough signal is getting to where it needs to go because there's pressure on the nerve. And we talked a little bit about treatment as far as what we can do non-operatively, as well as very briefly went through the surgical technique and what you can expect post-operatively. Personally, carpal tunnel syndrome is probably one of the top 3 things I see in my office as far as the number of patients I see a day with a specific issue. And the great news about carpal tunnel syndrome is it's very treatable. So the vast majority of patients who have shown up in my office, 90, probably 5+% who have carpal tunnel syndrome, were able to treat it effectively, whether it be non-operative treatment with splinting and injections, or if necessary, operative treatment with surgery, and they get back to doing everything that they wanted to do or needed to do before their diagnosis. So now I'm happy to take some questions. I don't know if Dan wanted to start things off, or we can start off from anyone who has any topics of discussion that they'd like to share.
Yeah. So I've actually received a few questions already, but thank you, for taking the time. It was a great presentation, and hopefully everyone learned something. And, if they have any questions, they can shoot you a phone call at your office. But a few that I have received. So it's something I think you mentioned earlier, but the question is, so my hands fall asleep in the middle of the night, no matter what position I sleep in, causes me to wake up. I wake up with tingling. My PCP says it could be carpal tunnel. It happens throughout the night. Is this a sign that I have carpal tunnel?
Yes. So as I mentioned before, I think those are fairly classic initial findings where you have numbness, tingling, burning sensation. A lot of patients will tell me they wake up in the middle of the night and have to feel like they need to shake their hands up up to wake them up. So I certainly think those are all signs that would point towards that direction. Obviously, an evaluation by an upper extremity physician, myself, or someone else in the Trinity system would be very helpful to determine what the next steps are. But yes, those are pretty classic textbook findings of carpal tunnel syndrome.
Jerry, I see you have a question. If you'd like to unmute yourself, you can feel free to ask. So let's see. So the question is, oh, go ahead.
I got it. I had 2 quick questions. If someone's on blood thinners, is this going to be a problem, that type of surgery?
So it depends a little bit on which blood thinner, and obviously you don't have to share that in this forum, but I've never had a case that we haven't been able to figure out a way to do if a patient is on a blood thinner. So we can easily work around that in several different ways, depending on the type of blood thinner, the reason that you're on the blood thinner, et cetera. So I've never had that be an impediment to moving forward with operative care of carpal tunnel syndrome.
Okay. And the last question was, I do get numbness and tingling every night. It's over 2 years. Can carpal tunnel also cause that same arm to have a burning, hurting feeling in the upper arm on the outside, or is that something not related?
So most of the time, and I say this most of the time because every case is a little bit different and patients report different findings, because everyone's different. Everybody has different biology and experiences. So But I would say that the majority of the time, carpal tunnel syndrome, if you have a compression of the median nerve at the wrist, will only cause symptoms up to the elbow.
Okay.
So you can see forearm burning, tingling, pain.
Mhm.
I don't generally associate, and it wouldn't be generally associated with symptoms in the shoulder or the neck region. And again, that's one of the reasons why we do those electrodiagnostic studies, because it's very helpful in determining if there is other compression
Okay.
more proximally, which means towards the neck. So often we will see patients with symptoms just like you described, and we get a nerve study and it shows a little bit of compression of the nerve towards the neck and compression at the carpal tunnel. And that's what's called a double crush phenomenon. I didn't go into that because it's a little bit more detailed than I think we had time for, but that is not an uncommon finding.
I know I have it in the fingers for over 2 years, so I think I'm going to have to make an appointment.
Sounds good.
Thanks, Jerry.
Thank
And
you. It was very
Debbie.
informative. I enjoyed it.
You're
Debbie,
welcome.
I see you have a question. If you'd like to unmute or.
Okay, I'm unmuted. Yes.
Perfect.
Can you hear me? Okay. I actually have 4, but I'll go through them really quick, and I promise I won't take up a lot of time. Why is it called a syndrome and not an injury or some other definite medical condition? What does the hand-wrist repetition rate actually mean, and how is it measured? Don't steroids actually delay the inevitable of surgery? And when the ligament is released during surgery, what does it actually mean? What happens to the ligament when it's released?
All right, so let's go through that. I may have to ask you to repeat, but the first
That's
one was what again?
Why is it a syndrome and not a specific injury?
Yeah, I don't have an answer for that other than the fact that, you know, it's usually not associated with a specific injury. And so a constellation of symptoms. So as I described, you know, you have all these different symptoms. So, you know, you have numbness, tingling, burning, you might have weakness, you might have loss of sensation, pain. When we describe medical presentations, you know, patient presentations, generally when it's a constellation of findings like that, we call them a syndrome versus an injury. You know, it's a way we describe it. It doesn't have any, you know, qualifying reason why we call it a syndrome, but yeah, it is what it is in some ways. The second one was repetition.
Yeah, what's the hand-wrist repetition rate? What does it actually mean, and is it measured in some way?
No, we don't generally measure it. You know, the way I look at it is if you have a job that requires, you to pick up something and put it in a specific place, you know, frequently over a day, then you have a high repetition rate. Or people who run machines, I see a lot of people who work in machine shops or factories in the area I practice, and you know, I always do a pretty detailed history in those cases of their work activities, and often you realize that they're moving their wrists back and forth, you know, 1,000 or 2,000 times a day, and that certainly is a risk factor.
Okay, and do steroids really delay the inevitable of surgery?
So it's a good question. So I see this in 2 different ways. So there are certain cases of carpal tunnel syndrome that, let's say, you rented a jackhammer for the weekend because you are building a pool in your backyard and you ran into a rock. And you don't normally use a jackhammer. So you rented a jackhammer, used it for 2 days, you blasted through the rock, and then a week later, your hand is killing you, and you have what's called essentially an acute carpal tunnel syndrome, meaning that you didn't have any risk factors prior, but that one activity caused that nerve to swell. So if I inject that with a steroid, it may reverse that, and you may reset. You may not need surgery.
Okay.
So
and
if you have a chronic, no, that's fine. If that answered your question, that's
during surgery, when the ligament is released, what does that actually mean? I mean, a released ligament, what happens to that ligament once you release it?
So you cut the ligament. So you think of it as sort of like a roof, you know, like a lot of these football stadiums nowadays have these roofs on them, right? So you're opening the roof. So you're relieving the pressure on the nerve. Over time, that ligament will heal. It will actually reform it. And that's that's one of the reasons why you can get recurrent carpal tunnel. So I've had patients who come in and say, well, it can't be carpal tunnel because I had surgery 10 years ago. I said, well, it actually can, because you can have that ligament regrow and you can redevelop carpal tunnel syndrome.
And one last quickie, do you prefer the endoscopic surgery over the open surgery?
On primary, uncomplicated carpal tunnel releases, yes, I do endoscopic 95% of the time. On any revision cases, if you've had it before, had the surgery before, the endoscopic technique is not indicated and is actually dangerous. And so those obviously I do open.
Okay, thank you very much.
You're welcome.
And Stanley, I see you have a question.
Can I talk?
Go right ahead. We can hear you.
I had carpal tunnel surgery about 1.5 years ago because I was having tingling in my first three fingers every night. Well, I had the surgery, and so far that has not worked. I still get tingling in my 3 fingers at night. What's going on?
So how long ago did you have the surgery? I'm sorry, I missed that part.
1.5 years ago.
1.5 years. Yeah, so that's a little bit long to still have those symptoms. So
Yeah,
it certainly would be worthwhile being reevaluated for whether or not there's a recurrence. So there's 2 different types. Let's say you had symptoms, you had surgery, and then you still have symptoms. So there's what's called recurrent carpal tunnel, which means that the symptoms went away or got a little bit better, but then they now have come back. Or there's what's called recalcitrant. Recalcitrant meaning they had surgery, you had symptoms, you had surgery, but the symptoms never got better. So in severe cases, the symptoms may take 6, 8, 10, 12, even 18 months to go away. But if you've had no improvement or have had a recurrence of those symptoms back to where they were before surgery, my recommendation, based on just what you're saying to me, would be to have another evaluation by your surgeon or somebody who's knowledgeable to determine whether or not there's something that can be done to improve those symptoms.
Okay, I understand. The symptoms have lessened somewhat, and sometimes they're completely gone, but they still occur. It just at night when I sleep in a certain position, it seems like my arm is being pinched. Is there a nerve that extends from the arm into the wrist area?
Well, the median nerve does. It comes all the way from the neck all the way down through under the collarbone and down the arm. So I would say it's probably, if you're still having some symptoms, it's probably worthwhile having somebody, myself or whoever did the surgery, to take a look at it and just make sure that everything looks appropriate. It's hard to, unfortunately, because we're doing this virtually, it's hard to kind of look and see and feel the arm and look and see how the nerve is working.
How does he look at it?
Okay, I guess that's what I'll have to do. Thank you for your help, Doctor.
Yeah, you're welcome. You're welcome.
All right, Dr. Carlson, we received a few additional ones. Is surgery full anesthesia or local?
It's a local anesthetic. Patients can decide whether or not they want to be awake or have some medication to make them drowsy. It's not general anesthesia. So it's what's called a local with sedation usually, or a straight local where you're wide awake. And that's really up to the patient's preference.
Okay. Does golf aggravate carpal tunnel?
It's a good question. I would say that normally that's not an activity that's related with carpal tunnel, but certainly if you play enough, I can see that it may cause a little bit of aggravation. But it is certainly not an activity that is on the top of the list of high risk factors. I guess it depends on how many divots you're taking.
I guess 2-part question. What would you tell someone who's afraid of getting surgery, and what are the risks of surgery?
So the risks, I'll start with the risks. So the risks of surgery are obviously that the surgery doesn't work, which it can. There's very rare instances where you do the surgery and you do it correct and it doesn't get better, or it's not completely released the first time and you have to go back. There's always a risk of anesthetic complications. Even in local anesthetic, you could have a reaction, or you could have any type of reaction with the IV medication if you do choose sedation. There is a risk of infection, which is very uncommon, especially in endoscopic carpal tunnel. I mean, we're talking less than probably 0.5%. And the vast majority of the time, if you do have a little skin infection following surgery, it can be treated with antibiotics you take by mouth. It doesn't require another surgery or IV antibiotics. Those are probably the main risk factors. There are some patients that develop stiffness in the fingers following surgery, but that's, again, as I mentioned, very rare. I very rarely send patients to physical therapy because most patients come back after 10 days and their fingers are moving fine. They just have a little soreness over the area of the palm. As far as, if you're scared of surgery, I think the question is, what is it about the surgery that scares you? And if, you're in my office, and I would ask you the same thing and try to work through that. And if it's, anesthesia, we can talk about that. If it's you're worried about it not working or the pain. I mean, I think, it really depends on why you're worried about, or what you're worried about surgery. And we certainly would work together to address that, to try to make you feel comfortable if you do need the surgery. I think one thing that I want to stress is that, not every patient that gets diagnosed with carpal tunnel syndrome needs surgery, right? So there's certain things we can manage. Maybe it's just a night splint. So it's certainly not every patient that comes into my office, even though I'm a surgeon, they don't leave with an appointment for surgery.
With the endoscope surgery, how soon can I return to work if I'm a pharmacist?
So depending on the workplace you are in and your comfort level, I've had patients who are physicians go back to work the next day. You would have to wear a dressing. The wound usually takes 10 days to heal. The sutures are still in for 10 days. So if there's any concern of contamination or the workplace doesn't want you to work with a dressing on, then I would say 10 days. But once the dressing is off and the wound is healed, I really don't restrict patients other than say, be careful, try not to put a lot of pressure through the palm because it's going to hurt.
Okay, great. Can addressing weight and pre-diabetes help improve symptoms and avoid surgery?
Yes and no. Certainly, there is both of those issues, weight and diabetes, do increase the risk of carpal tunnel. It isn't as effective, though. Decreasing your decreasing your weight or improving your diabetic control doesn't necessarily improve the health of the nerve. Once the nerve starts to have some damage, it kind of has damage until it's released. So it's not as effective, controlling those two issues it's not as effective in carpal tunnel as it would be in, say, dealing with arthritis of the hip or knee, where you really see a almost, linear improvement in your symptoms with the improvement in those two issues. So I would say it certainly wouldn't hurt, but I haven't seen a drastic improvement, and I've never actually seen a study in that. And it's an interesting question. But I've never seen an actual study, so that's sort of anecdotal.
Okay, so I know we're running up on time, so we have two last questions that I'll ask. So let's see, I was diagnosed with carpal tunnel and have been wearing a brace, and it helps a lot. When should I worry if I do more damage than good, or should I consider surgery now?
So if the splint, so let's say I'm just going to sort of assume that the symptoms were mostly during the night if you're wearing the splint and the symptoms have been relieved. It's not necessary to have surgery if the symptoms are improved. And for what we can tell, you're not doing further damage to the nerve. So I would say if the splint is working, I would continue that. That being said, if the symptoms do come back or become more persistent, despite splint wear, I would certainly follow up with your physician.
All right, one real quick one before I ask the last question. By any chance, do you know if Medicare covers the less invasive surgery?
So I would say the answer to that is, in general, yes. I don't, it would depend on the plan, but I've never had a Medicare plan deny the endoscopic technique.
And then last question is, this person had carpal tunnel for 15 years. They still have numbness and lack of motor skills. They let it go for years and it has impacted writing, motor skills, and sensitivity. What is your recommendation? Having another surgery, PT? What do you think?
Well, that's a difficult question to answer without all the information. I mean, I think certainly it deserves an evaluation and probably a repeat electrodiagnostic study to see where the nerve is. And somebody asked, so how do you see the nerve before? And that's based on, I'm not saying I can actually see the nerve, but you can see how the nerve is working by a clinical exam and these tests that we can do. So I think that's a complicated question to end with, but if you've had surgery, even if especially if it was 15 years ago, and you've redeveloped symptoms or the symptoms never really got better, then I think a reevaluation is definitely warranted, and some investigation needs to be done.
Perfect. Well, thank you. And just for real quick, our ongoing webinar series. So we have Dr. Daniel coming up in 2 weeks. And he'll be talking about knee arthritis. So if you haven't joined already, feel free to go to our website and register online. And then we have Dr. Kim coming up in November, and then Dr. Sprague for shoulder in December. And then just some things we offer here, orthopedic surgery, we have CJRI in Hartford, we have sports medicine, and then just some, awards. And then if you want to get in touch with Dr. Carlson, feel free to write down phone numbers at both locations, and hopefully he can help you out. And that concludes our presentation. So we really appreciate it. Appreciate taking the time, and thank you, Dr. Carlson. It was a great presentation, and hopefully everybody has a great night.
Weakness in the hand, and this, see how this is like caving in? That could be it, because this thumb and this